others. I never get fatigued talking about fatigue. I live it, breathe it, and study it.
Awesome. Grow up.
East Coast,
Okay.
Connecticut, Waterford,
Uh-huh.
Waterford, Connecticut. Initially, the first 5 years was in Brooklyn, New York. So I've always gone Brooklyn, and then I lived for about 20 years in Connecticut before finishing up college and going elsewhere.
Yeah, and then have you pretty much been in California
Yes,
the majority?
except I did teach and work at the University of Nebraska Medical Center in Omaha, Nebraska. So with Peyton Manning recently retired
Uh-huh.
in Omaha. And I remember when I moved there initially, one of my friends said, Barbara, you have to get used to it being an echo city. And I said, what do you mean, George, an echo city? He said, well, when people ask you where you come from and you say Omaha, they say Omaha.
That's funny.
Well, I think I was going to be the world's first female neurosurgeon.
Oh, nice.
That was when I was 16, and I decided that I really wanted to be a mother too, and I didn't see that kind of coinciding back then. So I also was raised by a German first generation father, and my mother was Polish Lithuanian. And my father said, thou shalt know what you want to be when you grow up at the age of 16. And I said, okay. And so I went to work as a nurse's aide. I took a course at a local hospital. My mother was a nurse. She had graduated from a diploma school in New York City. And I loved it. And I never looked back. So I went through, fortunately, I was able to go because my mother had a diploma program education. She had always wanted her daughter to be a BSN prepared nurse, and my father was the only one in his family who went on to school in college. Women in the family did not go on to college then, so I didn't realize what a lucky break I was getting by just automatically being able to go into a BSN program. So I went to Syracuse University. At that time, the BSN program was 4.5 years, and then I worked. I worked the summer off my third year as a licensed vocational nurse or licensed practical nurse. And once we took the exam, we could go anywhere, and we decided it was going to be either Florida, California, or Hawaii. And California came through first, and we didn't have to have the license in our hot little hands. So we went to work in LA County USC Med Center back then. And it was just the start of nursing specializations. I worked in the ICU, and my college roommate from Syracuse went to work in what was called the chest unit, which later became the CCU. And we were getting antsy to maybe get married, but we wanted to see the world first. So we traveled across country again and then went to Germany. And we worked as Department of the Army civilians in Heidelberg, Germany, where the United States Army had their European headquarters, aka USAREUR. Yeah. And I worked as a staff nurse in med-surg unit and also ICU, and met my husband there, and we stayed there until he decided to get out of the Army, which was shortly thereafter. And we came to work and live in California when my husband was accepted for his MBA at Stanford.
Uh-huh.
Well, I had wanted to do initially the Roy adaptation model, and I was working on a cancer research unit at that time in California, and I said, I wonder if oncology nurses using the Roy adaptation model to do their assessments and their interventions make a difference in patient outcome. And I got another nurse to help me do that. But then I came into contact with a patient who I think I describe in the course, who had acute myelogenous leukemia. And she had gone through her induction chemotherapy very successfully, in the sense that that was to induce a remission and get rid of abnormal cells or blasts in the bone marrow, and she had less than 5% blasts in the bone marrow, which indicated remission. And they wanted her to undergo consolidation therapy, which would consolidate the remission. And she was refusing that. And I wasn't too sure why she refused it. So when I had time, I sat down and I started talking with her about it. Not that I wanted to necessarily change her mind, but I just wanted to make sure that it was an informed decision that she was making.
You could understand her thinking.
Mm-hmm.
Yeah.
And so what came of that was that she said, Barbara, my quality of life was terrible. I've been in the hospital for 5 weeks, nonstop, and I think that's still the case for many leukemias to induce a remission because it's pretty heavy-duty regimens that they use. And she said, and the fatigue was overwhelming. Now, I don't think she used the word fatigue at the time. She might have said that the tiredness was overwhelming. And so I began to think, if I would have recognized it earlier in her, even though she was going through such a humongous treatment regimen, would it have made a difference and prevented it from becoming more chronic? And of course, when you have leukemia, you have abnormality in the cells, and then when you eradicate all the cells in the bone marrow, you have obviously anemia and risk for bleeding and infection and etc. So I thought, well, I'll look into this a little bit more, because obviously somebody has made a study or a paper on the relationship between anemia and fatigue. Zip.
Really?
Nothing. We had always assumed in practice that anemia was related to fatigue, but no one had ever studied it.
Wow.
Nothing had been published on it. And so that got me curiouser and curiouser. And so
Can I interrupt?
Yeah, sure.
When did you start that process of, what year was that when you started?
Okay, you're going to call me a young lady now, I know, Heidi. I was working in 1976
Okay.
As a staff nurse on the inpatient cancer research unit at UC in San Francisco.
Okay.
And that's where I was working full-time because I was missing practice. I was teaching in an associate degree program, and I was missing practice. And so I wanted to go back, and that was this time that cancer nursing was just becoming identified as a specialty. So ICU was the first known specialty, and I think you talk a little bit about advanced practice at the master's level and beyond. And so that was just the start. ICU started, then CCU, and then oncology nursing. The National Society formed in 1975, and I was one of the founding members, charter members.
Okay.
My scale has fatigue that can be divided into cut scores: 0, none, 1 to 3, mild, 4 to 7, 4 to 6, moderate, and then 7 to 10. And so we're showing that what's the incremental clinically significant difference if you're at a 7 that's bringing you down to a moderate level.
Would that make
Would
a difference?
that make you feel better? The other thing is there are 4 dimensions in my scale. And so if we know the score for the behavioral severity is higher than, say, the emotional one, does that mean then that we should target our interventions for that underlying dimension? Does the dimension that's the worst on the fatigue scale give us any more information about interventions?
Sure.
And we don't know that yet.
Yeah. Well, and it could be different for every person that answers it.
Or you begin
Or you can find a pattern.
Or you
Yes.
find a pattern.
Yeah.
And a group of patients that react the same way, like chemotherapy patterns that are offered on that or treatment cycle. When can you predict when the fatigue is going to be worse?
Right.
And what can you do in between time?
Right. Yeah.
If you're going through radiation therapy, where you consistently have a rising fatigue level, that you begin to think, well, maybe this treatment isn't working. So that's another nursing intervention that you have to prepare patients ahead of time. It doesn't necessarily mean that you will experience the same pattern. However, most patients do, and so I want you to be prepared for that. When you're talking about conceptual models, which I would say mine is more of a conceptual model schematically, and I think I sent you a copy of that. And also, it's been described as a middle range theory, but I developed it purely as a practice theory. To me, I liken fatigue to affect quality of life. And quality of life, I think, is that grand theory, which has certain dimensions to it. But my theory and my thought was that it came from practice, it came from a patient. We are practice disciplined, and I wanted something that would help guide my assessments of patients and my interventions to improve patient outcomes and perhaps prevent fatigue from becoming chronic, which would be 1 month or longer in my definition of it. So you'll see on the level of abstraction, the grand theories are more encompassing man, person, environment, health and nursing. That's a grand look at whatever. And then your middle theories try to address those, if you will, pieces of the meta paradigm of nursing, and to try and explain how nursing differs from medicine. And that historically, I think, is the part of the middle range theories, or sometimes they're called the grand nursing theories, Newman, at Roy, and so forth. But because other people have taken those theories and have begun to study them in research studies and look at how they could be explicated for practice, there's that overlap. But mine was always directed toward trying to understand fatigue from a practice standpoint. What could I, as a nurse, do to explain what I was seeing and organize it to look at how it might enhance energy and or decrease tiredness and prevent the fatigue from becoming chronic.
Right.
So I would say it's a practice-based theory. But again, that's my opinion. Well, I think looking at the model, I wasn't looking at the meta paradigm. I was zeroing in on one symptom and the causes of it. And so when I look at the person being fatigued, I look at their symptomatology, both in terms of subjective, patient-reported outcome, as well as underlying physiologic, observable, objective measures that can measure fatigue. So if you look at my model, I have 6 dimensions with physiologic always underpinning it. And if you go around the model, the innate host factors is probably a major portion of where person is identified, because it's the things that are part of us that I, as a nurse, would not be able to change, although that too is changing with scientific advancement. And we can't change the person's age, we can't change their gender, and we can't change their genetic makeup. And so that's why I'm saying that it's a shifting field even that way. But then around the model, you have various components of activities of daily living. You have activity exercise patterns, sleep patterns, you have nutrition patterns, or altered transmission patterns with the neurotransmitters, psychological patterns. All of those things affect the person, and they can be modified both to enhance energy and decrease fatigue. And then you get into treatment patterns, because I was, again, working as a nurse and looking at treatment patterns. And treatment from a cancer perspective can include a number of treatments, chemotherapy, radiation, and so forth. And they come to find that they have different patterns of fatigue that people experience.
Depending on the treatment that they're getting.
Right. And as the disease responds to treatment, then you might be expected to see fatigue change and energy levels perhaps come back up to baseline. Sometimes they don't.
Right.
So what's going on
yes,
there?
What made the difference? Yeah.
Okay, so using the model, when I did individual patient consults, I go through the model. I ask them, first of all, what kind of symptoms they're experiencing. Do they notice anything in terms of circadian patterns? What time of day is better, worse for you? Because people who are more tired in the morning versus later at night before going to bed tend to be perhaps more depressed, and maybe that might be a factor. I also ask them, what do they think is the primary cause that they're experiencing, or reasons that they're experiencing fatigue? And usually they'll identify 1 or 2, or they'll just automatically say it's my disease or it's my chemotherapy or what have you. So that gives me a clue as to what the person believes is most likely causing their fatigue. But because of my work in it, I know that by the time they know that this is different than usual tiredness, that it's multi-causal. There are multiple factors that are involved with it. And you have to do a multi-causal intervention. So you address if it's depression, you look at how you can help in that area, whether it's making a referral or doing some counseling or cognitive behavioral therapy. If it's anemia, we look at did they get any kind of medication that would help their iron stores or start bringing up their counts. So it's, and then if they're not eating properly or they're losing weight for some reason, then a referral to a nutritionist. So it helps assess, and I've used it doing patient consults, and I've used it for prescriptions as well. I've used it to guide research, and others have used that model to guide research as well. Has been. Yeah, it's also been used in multiple sclerosis patients, student nurses, women with breast cancer. It's been used internationally with other groups, cardiac patients. Two comments on that I have. I remember sending student nurses out clinically to interview patients about their tiredness and fatigue. And one nursing student came back to me and she said, the patient doesn't know what fatigue is. And that was culturally different. And then I worked with a nurse scientist from Switzerland who said, Barbara, you Americans are so lucky. You have multiple words for fatigue. We have only one, müde. Ich bin müde. I'm tired. And that's it. And I said to her, Agnes, that might make it easier to research.
That's what I was going to say. Maybe it'd be easier, yeah.
So I had to develop an instrument. Once I realized there were only 2 studies out there at the time that really had the person's perception of fatigue. That was for Air Force pilots, the Pearson-Byers feeling fatigue tone scale, and then, interestingly enough, the Japanese Industrial Research Committee on fatigue. They had a 30-item, multi-item, fatigue instrument. And thank you. Well, I think we have some emerging evidence in, meta-analysis and also in further work with looking at the randomized clinical trials that we now have that really say that exercise is a very good intervention, very strong intervention when compared to energy conservation. It's stronger than that. It brings about more of a reduction in fatigue.
The opposite of what you would think.
Yeah, and so you have to look at exercise that can be tolerated by people with different diseases and different stages of illness, and also the time in which do you give the exercise during treatment? Do you give it after treatment?
Yeah.
How do you monitor safety factors?
Right.
All of those issues. We don't have a lot in nutrition, and we're looking at genetic differences. And so that might give us some additional information, because we do know that from the genetic studies and fatigue that Chris Mieszkowski from UC in San Francisco and others have done, that there seems to be 3 different kind of patterns. People are low on the symptom with other symptoms. People may be moderate on fatigue and other symptoms, and people are high. And if you take those baseline measurements and you follow them out over time, they tend to stay pretty stable. And so if you are trying to, as a nurse, trying to target your interventions to those at highest risk or those that are the hardest to treat, then you would go for those high-level patients. Mm-hmm. Or if you want to prevent it from going to moderate and severe, then you'd intervene earlier. So there's a lot more work to do. And I'm delighted that people are still using the scale that I have. And also we're continuing our work research-wise as well. I've got a grant that I'm doing with other people from the president of the university, the chancellor, and we're looking at putting the fatigue scale, the PFS-12, onto a mobile device, an Android or a iPhone, and also putting on the PROMIS 29-item profile. The PROMIS, Patient-Reported Outcome Measurement Information System, is something that the NIH has spent over $60 million trying to get all investigators on drug trials and other trials to use the same language. Fatigue can be defined in different ways.
Right.
It can be measured in multiple different ways. And so PROMIS has standardized the patient-reported outcome system. And so I'm incorporating that. It has a fatigue scale, and it also has depression, anxiety, mobility, that kind of thing.
Yeah.
So we're just starting that. We're much more focused now on patient-centered care. And now that we have, as an academic institution, National University is the first academic institution that is partnering with Plaintree. And Plaintree is a patient-centered organization internationally. So more will be forthcoming on that.